All right, so this is a review of Dr. Bueller's hip pain lecture. Hip pain. It's either due to injury or other random causes like arthritis, septic arthritis, gout, Crohn's, sickle cell, blah blah. But let's focus on injury. Okay, so how are you injured? Overuse, which is pretty common. Sprain, strain implies there's muscle involvement, depending on which part of the hip. And then you can also have fractures causing pain. Fracture of what? Fracture of the hip, the pelvis, the pubes. In the pubes, you have a triad. Know the triad. I'm not sure what it is. Also know that it affects young runners, so running is not good. And adductor tendonitis is a common sort of association with pube fracture. It makes sense. That's where they attach. Then you have pelvis. Pelvis, you have the pretzel concept, and the collateral damage is a very likely possibility. Actually, I made that up. I'm not sure if it's likely, but it's associated. Lastly, you have hip fractures, and there's different types, and I'm going to go over that in a second. Okay, so here they are. This is subcapital, I believe. This is transcervical across the neck. This one middle here. This one is intertrochanteric between the trochanters. This one is trochanteric, and so is this one. They sort of slice the trochanter off there. And this one is subtrochanteric. Voila. All right, so hip pain divided by location, anterior and posterior. The causes of anterior pain are derangements, osteoarthritis, apophysitis, muscle spasms, impingement, or slipped capital femoral epiphysis. That's all one word or one disease. Let's begin with derangement. It could be labral or cartilaginous. It shows normal X-ray, so you have to use arthroscopy to detect it. Patient presents with decreased range of motion, possible spasms, joint moves, and does a little popping, and it's pretty painful. How do you treat it? Injection and possibly surgery, I believe. Double check that. Then you got your osteoarthritis. It's usually old people. They show up with sort of history of progressive pain, and they're kind of overweight. And anyway, what do you do for them? You give them a hip replacement, but until that happens, injection. Anyway, so then you have apophysitis, this time young, growing athletes. Apophysis is their growth plates, where the muscle usually attaches. Slipped capital, you have active also, overweight, and it's usually male and right after puberty. Again, they show up with chronic pain, and they report intermittent limping. And surprise, decreased range of motion. And surprise, what's the best treatment? Surgery. Back of the leg, you can have pain if you have hamstring injury. Also, bursitis is categorized in the back. What's special about bursitis is that the range of motion is intact. Pain is on one side, very painful. You can't lay on that side. You can't use your glutes, and the greater trochanter is very tender to touch. ITB syndrome is another problem in the back. It affects athletes or people who have had a trauma and are having adhesions post-trauma. It's tested for by Ober's test, and one of their unique treatments is a roller. Again, general treatments are ice, heat, rest, and stretch. All right, so we have two different categories or classification systems for hip dislocation. We have Thompson-Epstein and Stewart and Milford. Let's begin with Thompson. We've got 5 categories. 1, it's minor fracture. There may or may not even be a fracture. 2, it's a single fracture. You see it. It's in the posterior acetabular rim, and it's large. 3, comminution of rim. Comminution. Okay, anyway, I will just say community. I will say community. Community of rim. And you could have a fragment or not, doesn't matter. And then 4th category is, 4 is floor, 4 to the floor, and 5 is femoral head is damaged, fractured. Okay, so 4, floor is fractured, 5, head is fractured. That's all of Thompson-Epstein. Stewart says 1, insignificant. 2, there's damage. There's a single comminuted posterior fragment, just like we had in Epstein, but it's stable during movement. And then 3 is instability that you can see, gross instability. And 4, you have a fractured head. Dislocations of the hip, another cause of pain. They're divided into anterior and posterior. Anterior subdivided into superior and inferior dislocations. They are both rotated externally, where superior is extended, inferior is flexed and abducted. So again, anterior dislocations are divided into superior and inferior. Superior is extended, inferior is flexed. Now let's talk about posterior dislocations. Actually, majority are posterior, 75%. In the case of posterior, you have internal rotation as well as adduction. Usually you see the patient with their knee across to the other side. All right, next is contusion and compartment syndrome. You could get compartment in the chronic form. Let's say you're a distant runner, or let's say you're congenitally predisposed and it just takes time. Or you could get it in an acute form via fracture or any sort of injury that causes bleeding. So you get contusion, or you could get it by a muscle tear. Patient presents with 5 P's: pain, pallor, paresthesia, poikilothermia, which means just feels cold, and pulseless. Alright, so next is avascular necrosis, abbreviated AVN. It's rare, usually adults. They're either drinkers or they use steroids. It's subacute, so don't be fooled. Happens bilaterally, so do MRI on both sides. And if you do surgery, it's treated with THA. I'm not sure what that is. Anyway, but don't jump the gun. Patient may not need surgery. There's an associated disease called Leclav-Perthes or something like that. It's an idiopathic AVN, happens in young boys for 10 years old. They present with a short leg and kind of limping, decreased range of motion. You do an x-ray and you see the ball of the hip collapsed and looks flat. And you say, okay, all right. And then you do an MRI. And that really shows you the problem. How do you treat it? Rest, cast, didn't work, surgery.